Good afternoon, everyone. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thank you very much for joining us on this week's COVID-19 webinar. As always, we have Q&A at the end of the presentation, so you can submit your questions in the chat box at the bottom of the webinar control panel at any time during the presentation. This is being recorded, so we'll send out an email to everybody with the link to the recording as well as resources that are mentioned. And at this time, I'd like to introduce our presenters, Dr. Nate Ruck, who's our CMO of Sound Emergency Medicine, Dr. Gregory Johnson, CMO of Sound Hospital Medicine, and Dr. Sergio Zanotti, who is our Chief Medical Officer of Sound Critical Care. So with that, I will turn it over to our CMOs. Guys?
Thank you, Mark. This is Greg Johnson, CMO of Hospital Medicine, and as always, we begin this webinar with a continued expression of our gratitude for all the work that everybody is doing with respect to responding to the pandemic. And we just remain incredibly grateful for the level of attention, professionalism, and quite honestly, just your participating in this webinar, so that way we can continue to provide you all with good information that applies to our patients. I think you guys are familiar with how we approach the agenda, and in terms of the updates, we'll spend some time talking about some timely issues related to ethnic disparities, and not just in COVID, but in general. We'll provide vaccine updates, some additional updates with respect to clinical guidance and testing, as well as an update with respect to clinical reopening, and then our usual Q&A. This is a pretty full agenda, and so we'll roll right into it. First, with respect to the Sound update. This is somewhat familiar to all, although we condensed it into just really focusing on the condensed it into confirmed and suspected cases from both our critical care and hospital medicine programs. And this is really through the beginning of this month, but from when we first started measuring it back in early March. You can see that the trend line is generally moving downward and pretty consistent with a lot of the data that is reason why we're spending some time thinking about reopening, what it means for our programs, and what it means for you specifically. But obviously, there's still a baseline number of cases, approximately 300 a day, that we're continuing to see across our programs, which means that we're still in the midst of dealing with this. There aren't any updates with respect to the overall mortality that we're seeing in cases that we're still and that we're still seeing essentially the patients that are over 50, and particularly those who are over 60, that are the bulk of the mortality in those cases. And so we're not sharing anything new in that particular data set. So one of the things that Sergio, Nate, and I wanted to make sure that this webinar did was, and part of what we've always tried to do is make sure that what we're doing is timely and topical. And I think we certainly, as an organization, aren't tone deaf to the fact that there is a lot going on with respect to race, ethnicity in this country. And that applies to healthcare as well. And it applies particularly to our patients. And so next slide, please. If we're really spending any time thinking about this, and making sure that we are living our mission of improving quality and reducing cost of healthcare, underscoring in the communities we serve, it's obligatory for us to acknowledge the fact that there is unequal treatment based on race and ethnicity in healthcare. And this is from the Institute of Medicine in 2002, so almost 20 years ago. And if I was going to underscore anything else in here, it's that independent of any other factors, it's African American and Latino patients are going to find something that's not office-based, meaning acute care, emergency medicine, hospital medicine, critical care. Those are going to be healthcare providers. These are our patients that we're talking about when we're talking about the disparities that are being experienced in this country. And so this is incredibly relevant to all of us. Next slide, please. The Institute of Medicine had a couple of summary findings, and this is extracted directly from that report, and that we'll make sure to provide access for you all afterwards. But finding 1-1 is probably the one that's underscored, and I think reinforces the fact that what's going on in our communities is absolutely something that has existed for a while, documented for over 20 years. We've talked about disparities for over 60 years in a documented form, and it's exactly as it says there. These disparities in healthcare are associated with worse outcomes, and I think we all agree to this, in many cases are unacceptable. There's a lot on this slide, and I'd underscore that, the finding that number 3, that health systems, providers, patients themselves may contribute to this, but the simple assertion that it's because many of these patients are refusing healthcare doesn't explain the disparities. There is existing bias, and that we've got to figure out ways to be able to address this. And so I frame this up in getting into the next few slides, which is really reinforcing the fact that for COVID, and that's what this webinar is about, there are a number of articles that really highlight very specifically that there are, like in many other instances, disparities with respect to outcomes related to COVID as well. Next slide. I underscore this again to underscore the point that the Institute of Medicine made, which is we've spent time in this webinar and highlighting other articles that clearly states that these conditions, among others, certainly not exhaustive, are contributing to poor outcomes for our patients. And that we've expressed concern for all of our patients and tried to be thoughtful in terms of pharmaceutical interventions, as well as other interventions that would materially impact their care. And as we've continued to think about these risk factors, we've also tried to figure out ways that we, as an organization that's honor-bound to improve outcomes, really are treating patients. But the subsequent slides, next slide please, indicate that these are issues that there are issues with respect to race and ethnicity that are affecting poor outcomes too. This is just an example that was extracted from a few studies, but noting that in Michigan, it's only 14% of the population, but for African Americans, but it's 40% of the fatalities. Louisiana, you can see the numbers there. And the Native American populations measured in Arizona, it's a significant, and as it's quoted in the literature, increased burden of disease within non-white populations. Next slide, please. It's also highlighted in terms of what we're seeing, not just at the state level, but in larger cities that are aggregating data and documenting what's happening within patients as the clinicians are identifying them, and the overall burden, not of morbidity, but mortality within those populations. And you can see there's a significant burden that is shared by non-white populations. Next slide, please. This is harder to read, but extracted from Johns Hopkins data and reported out in considerably smaller outlets. But again, communities that are dramatically affected by this in the Native American population, where, you know, these are actual cases per 100,000 people, not necessarily mortality, but it is significantly higher than that in comparison to white populations. Next data set. So part of the reason we highlight this is, yes, we are aware that cardiovascular disease, diabetes, among many others, are higher within certainly the African American and Latino population. But COVID is standing out because if you're looking at a couple other reports, influenza mortality is lower. Pneumonia mortality is lower for people of color, certainly in Medicare population. And so it's not just that we're seeing disease because for whatever reasons there's a higher incidence of this for treatable, primarily viral conditions. It doesn't necessarily apply. And so I believe that this is an indication that there's opportunity for us to consider what is unique about COVID, not just as a disease process, but how it's affecting certain populations of the patients that we care for. The next slide is also about disparities, and I acknowledge that these are also data from the MMWR that are the same reporting source as what we noted in the influenza and pneumonia groups. But when we're looking at inequity and things that are affecting our patients, we're also talking about violent injury and homicide, which is obviously significantly in the news. And the same MMWR report from 2019, based on data that was really from 2014 to 2016, underscore the same problems that were outlined with respect to healthcare specific outcomes. Racial and ethnic minorities are having inequitable rates of violent injury and homicide. For those where there is legal read police interventions, the death rate was triple that in non-Hispanic Black males than among non-Hispanic white males. And if you actually look at the last slide, which is deaths of undetermined intent that were associated with violence and legal interventions, the national average is about 3.2, and that for non-Hispanic Black males is obviously 5, almost not quite double. And for Native American, American Indian, or Alaskan natives, it's 4.9. I highlight this to say that I think not only from the perspective of what we're trying to address for our patients, it stands out well that all of these are healthcare issues. We would have to treat them differently, but part of what we're making sure to do is to make sure that these disparities are acknowledged, because without acknowledgement, we can't address them. Now, I won't say any of that is easy. The Institute of Medicine, you can go to the next slide, had some recommendations. And where we are starting as an organization is, and really as part of this webinar, is what is recommendation 2.1. Our first step is to increase awareness of disparities in healthcare. And based on Rob Bessler's email that he sent out to the organization, I know we are committed organizationally to making sure that we do a better job with respect to that, as well as 2.2, which is to make sure that all of our clinicians, all of our nurses, all of our site coordinators, all of our operators, everybody in Sound has increased awareness of disparities, because then we can effectively do our jobs. particularly for our patients, and serve our communities in the best way possible. Recommendations 5.6, really promoting equity of care through evidence-based guidelines is something that we have committed to doing, and I think between the three CMO, service line CMOs, and in conjunction with all other entities that Sound is involved in, we are reinforcing our commitment to this, because knowing that this provides equity of care is an important aspect of what we want to do for the communities we serve. Other things that have been mentioned, obviously, are multidisciplinary teams, but I think that also things that we have done historically, patient education and empowerment. For hospital medicine, that's the Patient Empowerment Project, but among other things, is to make sure that we're providing educational programs to make sure that our patients know how to access care. And very similarly in how we've discussed advanced care planning decisions, but also just really empowering our patients to be more involved in their healthcare, is to make sure that they are participating actively in their treatment decisions. And as recommendation 6.1 says, make sure that there's additional cross-cultural education, so that way we know that our patients are receiving this information in the best way possible and can actively participate. So that section ends there, and I know that we'll certainly be working, as Rob mentioned in the email, to continue to highlight not only disparities, but specifically what Sound can do, not just at the organizational level, but at the patient bedside level. We'll now move into the vaccine update, and I'll, in the interest of making sure that my colleagues have adequate time, we'll go through this somewhat rapidly. A quick recap, and this has been shared a couple of times. The image on the left is the SARS-CoV-2 virus as it looks, well, obviously in animation, but very specifically in the electron micrograph, and the real focus on the spike protein, understanding that the spike protein has a very specific binding area, and that, as you can see, there are really 6 areas where vaccines are being tested. The RNA vaccines, which are receiving the most press right now, still DNA vaccines, as well as some of the vector vaccines that exist out there. And then, of course, what we're most familiar with, the inactivated and live attenuated vaccines. Next slide. So lots of highlights that have come up since we've provided updates a few weeks ago. First off, the WHO notes that there are probably over 100 vaccine projects across the world. There are really 8 that are getting a lot of attention, and as of a few weeks ago, we're really in the early phases, phase 1 human trials. I think areas of optimism are really focused on the fact that per the NIH, or the director of the NIH, it was really, and I say this from the American perspective, once the disease was documented here, it was really 63 days before the first phase 1 trial was initiated. And because things are moving at such a pace, there is a lot of optimism that for healthcare workers, there would be potentially be available a vaccine within 12 months. Some have expressed, like Dr. Fauci, maybe something before the end of the year. And we'll get into some of that by the end of this particular portion of the presentation. Next slide, please. So this is a busy slide. I'll walk through this relatively quickly, but a couple of examples of what's gone on. So Moderna was the one that had, I think, the biggest splash in the news, at least with respect to what I've read, where they announced phase 1 clinical trials. They produced antibodies in 45 trial participants, and that because they've worked on other vaccines previously, They know that the platform is safe, and so they're really expecting to be in phase 3 clinical trials, which means broad trials, in numbers of 3,000 people, etc. That are really exciting, and part of the reason why the FDA has fast-tracked this, because it looks like there's a lot of promise with the Moderna vaccine. Inovio is another company that's really focused on DNA vaccines, and this one was a company that was really working on a vaccine for MERS, which, again, for familiarity's sake, is another coronavirus. And so that's why it is moving along at a reasonable pace as well. Again, about 40 volunteers that were in its phase 1 trial, and they're preparing for phase 2 or 3 a little bit later on this summer. The last one example that I'll mention is the University of Oxford. Again, they felt it was an 80% chance of success. They're partnered, as many are, and as the NIH director had stated, lots of not only academic but governmental institutions are partnering with private industry because they have more money and can move things pretty quickly. The University of Oxford vaccine, however, was really focused on animal trials. They think that they'll be in phase 2 to 3 clinical trials by the end of the year. And, again, a lot of hope when this originally came out in April about whether or not they would be able to produce something this year. So a lot of optimism within the vaccine front. Next slide, please. There are obviously ongoing issues. So there's been a lot of discussion in the ethics literature and within sort of the vaccine trial community of whether or not there should just be more human trials in order to make sure that we can get the vaccine out more quickly and broader distribution. And if you read these articles that are really talking about the ethics of this, some of it has to do with informed consent and the ability to make sure that you're getting enough numbers to make sure that the vaccine trials are adequately powered to determine safety. Safety, again, is the premise of the second concern, which is a lot of people are still concerned about the enhancement of the disease process based on a history of failed vaccines. Actually, if you look at HIV and the attempts on vaccines with that, as well as SARS, MERS, and even RSV in the 1960s, these are all examples of where providing the vaccine really enhanced the virus's ability to enter cells and subsequently enhanced not only the total burden of disease from a viral load perspective, but obviously the number of people who suffered from it. And so I think vaccine remains the primary concern. Lots of people are looking for ways to expand human trials, but there's still a great deal of optimism on the fact that things are moving at pace, and especially when you consider the fact that we're talking about a potential vaccine available within 12 to 18 months, and usually a new vaccine takes 5 to 10 years. With that, I will stop and turn over to Sergio.
Thanks, Greg. Next slide. So today for the clinical guidance update, we're just going to focus on what has emerged since our last webinar regarding chloroquine, hydroxychloroquine, remdesivir, and just a little bit of comments on convalescent plasma, which are the main therapies that are still, I think, being pushed and that some people are talking about in the literature, but also in the news. Next slide, please. So with the hydroxychloroquine, obviously there's been a tremendous amount of controversy, and I think a lot of also political posturing, and unfortunately it's detracted from really paying attention to what the science says. These are two studies, opposite spectrum of findings, that I think have been kind of surrounded by some controversy, and that I think that really relate to a lot of what's going on with COVID-19 and publications. So the first study was the French study with 23 patients, of which they lost several to follow up. And based on a very small number and very questionable scientific rigor, a lot of people jumped on that bandwagon, suggesting that there was clinical proof that hydroxychloroquine with azithromycin would also be interesting. That study has received a lot of criticism, and the society that sponsors the journal where it was published really came out with a statement that it did not meet their publishing expected standard. The study was not retracted, but it's still present. But it's really raised a lot of concerns. I mean, because it's a very, very small study with a lot of limitations, yet a lot of people, I think, have pushed that narrative and overreached in terms of what we really know about this drug. On the other hand, a more recent study that had 96,000 patients that was done through a large database, kind of aided with AI, was thought by many, because it showed that hydroxychloroquine was not only associated with no improvement, but with potential harmful outcomes, that would close the door. However, that study, published in Lancet, has also received criticism and some inconsistencies regarding the data they used, some questions about the database that they used that might be a commercial enterprise, and it prompted a very stern letter to the Lancet from over 200 scientists from around the world that really, I mean, raises some questions, not to the findings related to hydroxychloroquine, but to the process of that study itself. Now, based on that letter, the authors did publish a correction, but again, the study has not been retracted, and the findings stand still. So really, between two extremes, we can see that a lot of controversy, but no clear science. So I'll show you some of the studies that I think are less controversial and within their limitations might be the best guidance we have right now. Next. This is two studies I'm going to show very quickly on hydroxychloroquine related to observational studies done in large number of patients in New York City. This is one study that looked at over almost 1,500 patients admitted with COVID-19 to different hospitals within New York City during the recent months and the surge of the pandemic. And what they found really was, from an observational standpoint, that there was no difference in terms of the probability of being event-free, which was combined as an endpoint of intubation or death, where you use hydroxychloroquine or no hydroxychloroquine. So really not showing observational-wise any signal that there's any benefit with these patients when they're hospitalized. Next slide, please. In another study that had a larger data set of patients initially, but at the end resulted with around 1,500 patients being analyzed. Again, they looked at the association of treatment with hydroxychloroquine or azithromycin within hospital mortality in patients with COVID-19, again in New York State. And what this study found was that when you look at the Kaplan-Meier curves, the in-hospital death was highest with the hydroxychloroquine and azithromycin. It was no different between hydroxychloroquine and no treatment, no drug. And if they only got azithromycin as an antibiotic, it was actually a little bit better. Now, this is obviously an observational study again, but it also suggested that the combination of hydroxychloroquine and azithromycin was associated with a higher risk of cardiac arrest. So again, another large observational study showing that these drugs do not confer any benefits in terms of survival for patients with hospitalized COVID-19, and in this particular study suggesting that there might be some harm in the term of increased risk of having a cardiac arrest. So as of now, really there's no good studies that suggest that clinically there's any efficacy, and there's, I think, a growing body of literature that suggests that these drugs either have no effect or could be harmful, which I think should make us pause in terms of what are we doing with our patients. Next slide. The NIH, as of their current recommendations updated May 12th, really state that there's insufficient data to recommend either against or for, but really have talked about avoiding high-dose chloroquine just because of their potential for harm, but also that these drugs should really be given within the context of trials and not as a clinical treatment like a lot of people have utilized it over the last several months. And I think that, again, I mean, the lack of any solid evidence that they work clinically, and the growing evidence that either they don't work or could be harmful, should really be a reason for us to pause. And even though they're available and we've used off-label drugs in many other situations, I think for COVID-19, clearly there's a lot less enthusiasm for these drugs worldwide. The next drug is remdesivir, and this is, I think, the drug that's been studied the best so far, and that has shown, I mean, probably the greatest positive findings, even though by no means it's been a game changer. This is the first report that showed remdesivir as compassionate use. It was a report that included 60 plus patients, 8 of which were lost to follow-up, and basically they just reported what happened to these patients and stated that there was a higher likelihood of improvement if they used remdesivir from a respiratory status. Now, obviously, this was more of just a proof to proceed with clinical trials. I don't think that we can make any clinical bedside decisions based on a report like this. Next slide, please. The first randomized study came from China. This was a randomized controlled trial, 2-to-1 ratio. They used a 10-day regimen, 200 milligrams, then 100 milligrams per day. And they had 158 patients randomized to remdesivir and 79 patients randomized to placebo. Their primary endpoint was time to clinical improvement by day 28. Of interest is that they did not achieve the target enrollment because the numbers in the pandemics dropped in China this time. So they reported based on these findings and found no significant difference in the primary endpoint. And again, when you look at the viral clearance, there was also no significant difference between remdesivir and controls, which really, I mean, was a negative study, obviously kind of disappointing, but some people argued that it was underpowered and did not really achieve its initially target. So maybe we should still wait for more trials to come out. Next slide, please. This is the study that Dr. Fauci had commented on TV before it was published that I think created, I mean, the momentum or the energy to go ahead for the emergency use approval of remdesivir in the United States. This is probably the best conducted trial so far, over 1,000 patients, double-blind, randomized to remdesivir or placebo. For remdesivir, they got a 10-day regimen, which is 200 milligrams IV on day 1 and 100 milligrams from day 2 to day 10. And their primary endpoint here was basically a proportion of recovery, and that was defined by a different criteria. And what you can see here is that what basically they found, and they released this preliminary report, and based on this, the FDA approved, as you'll see, an emergency use authorization, that patients who got remdesivir as a total group had an improvement by day 11 on a median compared to those who got placebo by day 15. So a reduction in the time to clinical improvement that was defined as either discharge from the hospital or to remain in the hospital only for infection control criteria, but not for clinical criteria. Now, when you look at the graph on the right, you can see that this was positive for all patients, but more importantly, when you look at the baseline ordinal score, which really tells you what they were receiving, it was most effective for those patients who were receiving oxygen. And in terms of those who were on mechanical ventilation or high flow oxygen, the numbers were smaller, so it's hard to really tell. But really, I think that in those patients who were receiving oxygen, it seemed to have the biggest effect, and that I think is an important finding that influenced the authorization, emergency authorization, and the indication, as we'll see in a second. The last trial, next slide, please, that I'll share is a study that got published a couple of days ago, and it's really this was sponsored by Gilead, the company who does remdesivir, and what they were looking at is in patients who were admitted to the hospital, not mechanically ventilated on randomization or not on ECMO. They tried basically remdesivir for 5 days versus remdesivir for 10 days. And what they found was that if you look at the graph, and this was roughly 400 patients that were randomized, and you can see the the algorithm there. But when you look at the graph, what they're showing you is what they were on oxygen on day 5 versus the oxygen support at day 14. And what they were trying to see was the impact that remdesivir had on clinical improvement as measured by the requirement for oxygen or discharge. And the most important thing here is that those patients who were on low flow oxygen and ambient air on randomization were equally likely to have improvement or be discharged by day 5. Now, when you look at those who are on high flow oxygen and those who are invasive mechanical ventilation, it's harder to really figure out if there's a difference or not, but it's a much more complicated in terms of the outcomes. So what this study concluded was that in those patients who are in the hospital on oxygen, not intubated, not on ECMO, a 5-day course is probably as equal to a 10-day course. Now, this study compared outcomes in 2 groups that were receiving remdesivir. They were not blinded, so it doesn't really say anything about whether remdesivir makes a difference in COVID-19. It just says that 5 days versus 10 days was the same if you were on low flow oxygen, if you were on oxygen and not intubated or on high flow oxygen. So next slide. Based on that, the current recommendations from the NIH are that that remdesivir be used as a treatment for COVID-19 in hospitalized patients with severe disease that is defined as the need for oxygen or a saturation of 94% or less on room air, or those who are on mechanical ventilation and ECMO. They also talk about the need for continuous studies, and especially for those patients who have mild or moderate COVID-19 disease, but also talk about the emergency authorization, emergency use authorization by the FDA. I think it's very important to talk about how we should utilize remdesivir if we use it outside of the context of a clinical trial. And there's very precise guidelines by the FDA. Next slide, please. So the indications right now for remdesivir are patients with severe disease that are defined as those who have a oxygen saturation of 94% on room air, or patients who require supplemental oxygen, mechanical ventilation, and ECMO. There are 2 dosing regimens that are recommended by the FDA. For those patients who are either on mechanical ventilation or ECMO, a 10-day course is recommended, 200 milligrams IV on day 1 and 100 milligram IV per day from days 2 to day 10. For those patients who are hospitalized on oxygen or satting 94%, not on supplemental oxygen, but who are hospitalized, the recommendation is to go with a 5-day course, which is 200 milligrams IV on day 1, and then from day 2 to day 5, 100 milligrams IV per day. Now, what's also very important is that the FDA has provided us with very clear instructions in terms of making sure that we communicate to our patients or their caregivers that the FDA has authorized the emergency use of remdesivir, but is not an FDA-approved drug for COVID-19, that the patient or the caregiver have the option to accept or refuse remdesivir. We just can't prescribe it. We have to discuss it with the patients and their families, and we have to get some sort of consent. And then I think that it's also very important that we share with them all the information that we have on remdesivir, and that any information be given to them in written form, but also that we have a responsibility to report any adverse effects of these patients to the FDA. So the next slide is just shows you links to the resources that are available for patients and for caregivers from the FDA. Next slide, please. And those will be, shared with everybody on the webinar, and you can actually go to those links and print these out. But I think it's important as we keep moving. Obviously, we've been treating COVID now since March here in the United States. Clearly, data has emerged, studies are coming out, And it seems that hydroxychloroquine, chloroquine, azithromycin combinations are probably not effective or harmful, and we don't recommend that you use them. For those patients who are hospitalized, the drug that is now approved for emergency use is remdesivir. People should still try to participate in randomized trials if possible, but it is available in many hospitals. Now, this is not a drug that you can just acquire, so your hospital has to get it. It's been distributed, I think, through state or federal authorities, but many of our sound hospitals have remdesivir, and I think it's important for our clinicians to understand when and how to utilize it, and to be obviously following the data, because the FDA has been very clear that as more data evolves, they might modify the recommendations or they might change the emergency use authorization. So the last thing I want to talk about regarding therapies is just convalescent plasma for COVID-19. The idea here is that patients who had COVID-19 and recover will develop antibodies, and then we can draw blood from these donors, and those neutralizing antibodies can then be either utilized prophylactically, which is part of trials, or can be used for therapy in patients who are in the hospital, especially in those who are critically ill with plasma. Many hospitals, including I've used it clinically, are utilizing convalescent plasma as part of either registries or clinical trials. It has not yet been demonstrated to be something that makes a difference clinically. The preliminary studies have shown that it's probably safe when done within all the parameters that we utilize in our blood banks, but whether it really makes a difference for patients is still to be determined. So I think that most people who are utilizing it within some sort of clinical trial or experimental registry. Next slide. The FDA, the NIH, basically has said that there's insufficient data to recommend either for or against convalescent plasma, and that really it should be utilized within the confines of studies, which is what most hospitals are now doing. So I think that is a quick update on some of the antiviral therapies. And I'm going to hand it over to Nate, who's going to give us an update on testing.
Thanks, Sergio. Let's talk a little bit about what's happening with testing. There are, two buckets of testing which have been present for some time: PCR testing and other forms of testing based on viral RNA, antibody testing, and then the new kid on the block, which is antigen testing, which we'll talk a little bit about. Over the past few weeks, a new resource has emerged, which I think is worthwhile checking out for everyone on the webinar, and that is the Johns Hopkins Testing Insights Initiative. There's so much, there's, in addition to the viral epidemic, there's an infodemic, and wading your way through all of this information to find out what's actionable and what you really need to know is a challenge for all of us. And in addition to the resources at the end of this webinar, I would encourage everyone to check this out. So comparing the first two, the PCR tests look for evidence of active infection by looking for viral RNA. There certainly are cases where you can have prolonged positivity, as we've discussed on previous webinars, and they really don't give any information about whether you've had a past infection. And these tests in general are not emergency use exemption. They're FDA approved. Serology testing, on the other hand, comes in two forms. One form is done in a lab with high complexity machinery, and the other is done at the point of care. And both forms are released through the emergency use authorization. And these detect antibodies which document exposure, and nobody really knows whether those antibodies are neutralizing, i.e. do they guarantee immunity in the future. So there is a really great resource out there that was published in JAMA a couple of weeks ago, or almost a month ago now. And this is the reference. And here's a figure from this article which goes through, the light blue is positivity of the common nasopharyngeal swab PCR test. And you can see that in the pre-symptomatic period, during really the first full week, you develop a pretty significant viral load that's detectable via the swab. and that can continue for up to a month and a half afterward in some patients. And then you can see the two dashed lines, the purple and green, are IgM and IgG antibodies, which rise and fall as you would expect as your body mounts a response to the infection. And understanding a little bit of the nuance behind these different tests, when PCR is likely positive, when it can become negative, and the role of antibody testing is important knowledge for all of us to have. So the other piece of technology that's widespread and worth discussing is Abbot Labs ID NOW system. Many hospitals are beginning to open to, or have opened to, ambulatory procedures. And as they do that, many are requiring COVID testing for all patients undergoing procedures. And a lot of health systems are utilizing this Abbot Labs technology, which is similar to the PCR nasopharyngeal swab. It uses a technology called isothermal nucleic acid amplification, which has the advantage of not requiring any heating and cooling cycles, and the machine can give you positive results very quickly and negative results in less than 15 minutes. They've shipped about 2.5 million tests throughout the US as of a week ago, and the data that's out there suggests that the test characteristics are very similar to the PCR nasopharyngeal swab. And this is also under the FDA's EUE program. So antibody testing, as we discussed on a prior edition of this webinar, for the lateral flow technique, rapid antibody tests that are done either point of care at the bedside or in a testing center or in the lab, extreme caution is recommended. There are more than 120 vendors. There are numerous instances of fraudulent tests or tests that just don't correlate with reality. And I think we need to be very careful using the lateral flow analytes. There is more sophisticated ELISA antibody testing that some facilities that have moderate and high complexity labs may have available. These are useful, but collaboration with ID is still recommended. And the caveat, of course, and the thing to remember with all antibody testing is they're not useful for diagnosing active infection. Antigen testing, this received an emergency use exemption in the second week of May. Quidel Corporation, Sophia 2, it's a benchtop analyzer that's a little bigger than a loaf of bread that uses a fluorescent immunoassay that has a color change in the presence of the antigen. And I don't think there's enough data out yet to say, what the use case is for this exactly. There are some supply constraints in terms of obtaining the cassettes for this machine. There will certainly be a lot more data to follow. So that's an update on testing. Again, for more information on testing, I would point you at that excellent Johns Hopkins compendium of information that's updated very regularly. Let's take a few minutes and talk about reopening and what it means for us. So where have all the patients gone? I don't know about you, but there is, it's really, I think, incumbent on all of us in healthcare to get the message out that people listen too well to the message to stay home. There's, was a recent literature series that showed STEMI activations in a big health system were down 40%. I don't think anyone thinks that is due to the fact that there are fewer MIs happening. People are so scared to come to hospitals that they're staying home with conditions that clearly require care. So what are the reasons behind this? Hospitals are certainly seen as reservoirs of infection. The health systems have had so many competing priorities that getting really good information out about risk mitigation efforts for patients and what services are available, really hasn't been done in the way it should be. And, the national news focuses on extreme cases, and this skews public perception. And unfortunately, as Greg, alluded to in some of his content, the most vulnerable populations are, disproportionately affected by shelter-in-place orders and restrictions on travel. So there's a little bit of light at the end of the tunnel, or some good news here. This is a Gallup poll that was released yesterday afternoon. And if you look at the initial sample period, they sampled just under 7,000 people. For the week of March 28 to April 6th, 44% were very concerned about seeking healthcare in person. for the second to last week in May, from the 14th to the 24th, that proportion had fallen in half. So I think we're starting to see some movement in the right direction, but I again think it's incumbent on all of us to get the message out. So what can we do? You know, I think we really need to clearly communicate information about what's being done to mitigate risk, and clearly communicate information about what services are available. And I'm not going to go through this statement in super detail, but I'm going to point everyone to a New England Journal of Medicine Catalyst article, which has a link in it to a toolkit for how to communicate on social media, things you can do with hospital marketing, how you can talk to folks from your local press. And, you know, I think that there are lots of people being harmed by not seeking appropriate care. So transitioning to what do we expect to happen now that the acute phase is behind us in most parts of the country? What's going to be different? Certainly there will be, you know, we've heard a lot about telemedicine for really 15 years now, and there hasn't been wholesale adoption. That is changing, and there's, you know, a tremendous push behind use cases for telemedicine for a whole variety of indications. Elective surgeries, are those going to continue at hospitals which are seen as reservoirs of infection at the pace that they had previously? Probably not. What does that mean for us? You know, the ambulatory surgery volume obviously drives a lot of emergency department volume and inpatient volume. So I think there will certainly be an impact to us there. Universal source control, I think, is likely to continue for the foreseeable future. Contact tracing and infection control, I think, is going to be you know, a new facet of practice for those in the emergency department, certainly, and also practitioners of other stripes in healthcare. Home-based care, you know, when you think about what you would want for your family member, if they could be in place in their home and get the same level of care that they would get in a rehab or a nursing home, or even a med-surg bed in a hospital, you know, this is really going to be another area that there's going to be a lot of growth. So what does the opening up mean for us specifically? I think we are already seeing some continued COVID-19 prevalence, as Greg reviewed in the SoundWide data. We are seeing some pockets of release of pent-up demand and increased volume. We're also seeing some areas of kind of mild resurgence of infection. I think the good news there is that through preparation of the acute phase and practice using PPE, all of our practices have, you know, muscle memory on the things that we need to deal with any resurgence. We're also starting to see, certainly in the emergency department, but also other specialties, consequences of isolation, be they, you know, avoiding necessary care, running out of your insulin, exacerbation of underlying psychiatric illness. PPE, there continue to be PPE supply chain issues. We've talked about it before. Sound still has a supply of KN95 masks if you're at a facility that's challenged. And with that, I want to segue into some words from Mark Rudolph regarding provider well-being. And I think this is something that, you know, I know that Greg, Sergio, and I have been thinking a lot about. Mark has as well. And really, we need to keep an eye on each other. This has been an unprecedented stressor on healthcare delivery in the US, and as an extension, providers have been tremendously impacted.
Thanks very much, Nate, and thanks, guys, for the awesome presentation. As Nate just mentioned, you know, the stressors that so many of you have experienced at the bedside are not something that can necessarily be avoided, and we certainly don't want to try to suppress or toss aside any of the grief or the heartbreak that has been witnessed or been experienced with patients and families as well as colleagues. But I wanted to share something that I think is a piece of good news amidst all of this. And I'm sure that you've heard many people reference that there's going to be a second pandemic of mental health issues among caregivers. And that good news is that when you look at the data that surround some of the longer term sequelae of these experiences, things like PTSD, et cetera, what you find is that probably the most important and impactful thing is social support. The ability to obtain social support and even just the perception of social support plays a really big role in preventing or decreasing the likelihood of people developing PTSD. And so I want to just encourage everybody to continue doing what you're doing. I'm sure this isn't necessarily surprising to you, and I think you're all relying on one another very heavily, as you should be. But there are things that we can do, to even probably just to amp it up a notch. And if we go to the next slide, I want to share something that we talked about on the Coping with COVID call the other day. There's something called battle buddies, which is a concept created by the military. It's really simple. It's basically folks that have the same role and responsibility pairing up to offer mentorship and emotional support to each other, and setting up a scheduled debrief that recurs on whatever frequency you want it to talk about stressors and anxieties, offer each other some perspective, support one another's resilience, and also point out when, hey, maybe we should get a little bit more help here. Next slide. So I think we can all be encouraged by the fact that social support is perhaps the most important thing we have access to, and it's readily available. For those people that do feel like they need a little bit more help officially from somebody that they can talk to, Sound Physicians Peer Support Program is available to all clinicians 24/7. You can call, and you will be able to set up a conversation with a clinical colleague. Sound Physicians Employee Assistance Program we talked about is also available for any kind of issue that you may have, personal, financial, mental health. This is definitely a good conduit if you do want to get some kind of counseling, and you can see the contact information here. Next slide. And something that Nate first mentioned a few weeks back, there is a volunteer psychiatrist hotline called the Physician Support Line that's available to anyone for anything. And they've just recently extended their hours, so now they're available till 3 in the morning on the East Coast. Next slide. And finally, if you're ever finding yourself wondering, where do I get this information, because you don't have it readily at hand, it's all posted on Sound's Wellbeing portal, which is now available via a link on the soundphysicians.com website. If you look under the Tools tab, you can be taken directly to this page. Next slide. Please send us your questions, and here's a list of the links we've been sharing for resources. We've got just 2 minutes, and I want to ask a question that's actually not posted here, but somebody posed to me just this morning, which was, we're discharging all of these COVID patients from the hospital, and we're obviously very encouraged and excited that they're doing better. But given the rocky course in the hospital, is there any data emerging about how these hospitalized patients do? Perhaps from coming from places like China that were a little further ahead in the natural history of this whole process?
So I think that there's still not enough data of the long-term effects. I think that obviously there's patients who are critically ill, who have a longer hospital stay, and we still don't know enough about what's happening with those patients. But I do believe that the vast majority of patients with COVID-19 obviously still have very mild disease and seem to be doing okay. But that's a good question, and I'm sure that as time goes by, we'll get more information on readmissions, on what are the other complications related to discharge. But I don't think that there's a lot published yet that I have seen, at least. I don't know if Nate or Greg have seen something different.
No, I think I agree with your assessment. I think it's too soon to tell.
And I'm not aware of any data sources that indicate anything about post-hospitalization.
Great, thank you guys. We are at the top of the hour. Why don't we wrap up? Sergio, any closing thoughts?
No, I think that again, just thank all our clinicians for their work at the bedside. I think that if you take anything home today, I think is really the comments that Greg made on social disparities. And I think as clinicians, it is a risk factor for our patients, and we need to recognize that. And I think that we need to try to identify things that we can do at our practices to help move that forward. These patients, like Greg said, are coming to our EDs, our hospital wards, or our ICUs. And I think that based on what I've seen clinically, clearly minorities, especially here in Houston, we've seen a disproportionate amount of Hispanic and Latino patients who are taking the sickest in the ICU with COVID. So definitely recognize that within the context of what's going on today in our country.
Thanks, Sergio. Greg, final thoughts?
Hey, thank everybody for joining the webinar. Encourage anybody that's having has additional questions, please reach out. We reiterate, this is for you, and so we design the content for you. And just from the well-being perspective, and what Mark had shared, there's a lot going on, not just at the bedsides, but even now in our neighborhoods and in our communities, that reinforces our need to look after each other, to address well-being, to mean it. And I encourage you, for anybody, whether connected directly to me or not, if you need an individual to reach out that's within the organization, I certainly offer myself up, but I also encourage you to look over the resources that Mark highlighted.
Thanks, Greg. Nate?
Thank you to everyone for what you're doing. I think what we do has never been more needed by the country. And, I know I speak for Greg and Sergio when I say that our sole job is to support you. So if there's something we can be providing, whether it's the webinar or something else, please reach out and let us know.
Fantastic. Thanks, guys. Thanks for everything that everyone is doing on the front line. Keep up the great work, and we'll look forward to talking to you in a couple of weeks.